You are the FY1 in the surgery department on the morning rounds. You see a 45-year-old female who's day 1 post-laparoscopic cholecystectomy. She has increased respiratory rate, reduced oxygen saturation, and some chest pain. An X-ray has been done but not yet reported. The consultant turns to you and says, "Can you interpret this X-ray for me?" No worries. If you don't know how to read X-rays, this video will show you the basics of doing that. Divide your approach into 4 sections. First, you'll discuss the patient demographics, then the radiography details. Then we have the ABCDE approach for the interpretation of the X-ray, and then we will conclude. So the first thing you look at in an X-ray is the patient's demographics. You have a look at the patient's name, date of birth, their hospital number, also known as the MRN number. You check their age and their gender. You also check if they have any previous films done. Now that you're done with the demographics, you check the radiography details. That means you have to check the date when it was done, the type of X-ray that was done, whether it's AP, which is anteroposterior, or PA, posterior anterior, whether the patient is standing or supine. Then you check for the adequacy. You do this by using the mnemonic RIPE, R-I-P-E, where R stands for rotation. Check if the medial borders of the clavicles are equidistant from a spinous process. Then check inspiration. At least 5 to 6 anterior ribs would be visible above the diaphragm. Look at the picture area. You should be able to see the apex of the lung, the costodiaphragmic recesses, and the scapula should be out of the way. Check for exposure. You have to be able to see the vertebral bodies. Then we move on to the interpretation. This is known as the ABCD approach. First, you have airway. Check for any tracheal deviation. It may indicate rotation. Then you have B, which is breathing. Here you check the lung fields and compare it in thirds. Check if there is any air. This would be in pneumothorax. Look if there is any fluid, which you would see in an effusion. Check if there is any consolidation, which is inflammation in infection, lobar collapse, and check if there are any lesions, which might indicate presence of cancer. In breathing, you also have to check if there is any pleural thickening and look at the hilar region for any lymphadenopathy, masses, and calcification. C stands for circulation. Here we look at the heart size. It should be less than 50% of the thorax diameter on a PA film. Check the heart position. Maybe it is displaced if there is any lobar collapse or any large effusion. Check the heart shape and its borders. The right border of the heart is formed by the right atrium. The left border is by the left ventricle and atrium. Look at the great vessels. The aortic knuckle should be visible. D stands for the diaphragm. Usually, the right side is slightly higher because of the liver. In COPD patient, it appears flat. Check if there is any air below the diaphragm. It would indicate abdominal viscous perforation. Look at the costophrenic angles. Any blunting may indicate effusions. Finally, you have E, which stands for extra things. Look at the bones. Trace around the ribs for any fractures if you are suspecting it clinically. Look at the soft tissues for any swelling, any subcutaneous air, masses, or calcification of the aorta. Then finally, to complete your analysis, you have to examine any previous films and determine the clinical history. This is a simple interpretation of a chest radiograph, and it can be used for any other interpretation of X-rays.